This conference will now be recorded.
So yes, today we will be discussing this January 2020 talk, that is role of frozen thought embryo replacement cycles in assisted conception. Okay. This is actually the important talk, because this information you are not going to get in any theory part. Okay, not in any guidelines. Nowhere you're going to get this information. So please be thorough with this talk. Actually, not too big also, and it's very easy to remember also. So first thing, I think this slide is not important, but this is just the history. So first cycle first cryopreservation was done in 1983, and in the successive year, that is in 1984, first frozen thought baby born. Okay. So now the data from this HFEA, okay, HEFA, that shows that the live birth rate for frozen embryo transfer is same to that of fresh IVF. So remember this is sometimes the question they ask is, so frozen embryo transfer and fresh embryo transfer, the success rate or live birth rate is similar to both. Okay. But only thing, sometimes it can be biased, because this result can be biased, because remember the embryos which are frozen are only good quality embryos, and the bad embryos are discarded. So that's why the live birth rate might be similar for both of this. So frozen cycles, they are account for more than 30, so it is around 34% cycles. Okay, so frozen embryo transfer cycles are account for 34% of all IVF cycles. Now, why there has been increase in this frozen embryo replacement or frozen embryo transfer? So first, the thing is, there is improvement in this embryology technique. So exactly what do you mean by this cryopreservation of embryos? So cryopreservation means you have to preserve the embryos in the state of suspended animation. So this is achieved by freezing. So what happens in freezing is, the freezing increases the viscosity in intracellular and extracellular environment. Okay, so the viscosity is increased in both intracellular and extracellular environment, and it stops all the biochemical processes. But the disadvantages of this freezing is formation of ice crystals and the rise in the salt concentration, so which can damage the embryo. So how you are going to avoid it is by use of cryoprotectants. Okay, so the freezing is basically it is the increase in the viscosity of intracellular and extracellular environment, but the disadvantages of this freezing is the formation of ice crystal and rise in the salt concentration, which may damage the embryo. So this is avoided by cryoprotectants. So these cryoprotectants, these are of two types. One is permeating and another is non-permeating. So what do you mean by permeating? That means the cell membrane, they can travel to this cell membrane, and they drive the water out of the cell, okay, out of that embryo. Well, non-permeating cryoprotectants, they encourage this water out through osmosis. So they encourage non-permeating, encourage osmosis, while permeating drive the water, because it may makes the cell membrane permeable. Now there are two techniques of freezing. So one is vitrification and another is slow freezing. Okay, so cryopreservation, there are two techniques of this embryo cryopreservation. One is slow freezing and another is vitrification. So slow freezing, it was the technique which was initially used, and it takes longer time. Remember, it takes longer time. This involves dehydration of embryo, and it is achieved by passing the embryo through the series of low concentration cryoprotectants, and it is followed by a controlled freezing process. So whole process takes around 2 hours, and it requires a specific machine known as cryo machine. Okay, so remember, well, slow freezing, all are disadvantages. One is this, it is a very slow procedure, it requires specific machine, and it is very tedious job. Okay, and it is a controlled process. Why? Vitrification. So it is the most commonly used method now. Vitrification is the most commonly used method for cryopreservation of embryos. It is faster, more convenient. It takes only minutes. So usually there is a cycle of around 8 to 10 minutes. Okay, so it requires 8 to 10 minutes for freezing the embryo, and it doesn't require any machinery for that matter. Okay, it doesn't require anything. It just requires liquid nitrogen. Okay, it doesn't require anything for vitrification, and requires specific solutions known as vitrification medias. Okay, So this during this vitrification, what exactly is done is, so embryo is exposed to high concentration of cryoprotectants, and then it is cooled rapidly by exposing directly or indirectly to liquid nitrogen. So it is successively exposed to high concentration of cryoprotectants. Okay, so there are 3-4 medias are there. Media number 1, media number 2. So it is according to their concentration of this cryoprotectant, and you have to pass the embryo rapidly through these 3 to 4 medias, and finally you have to expose it to the liquid nitrogen to vitrify it, okay, or to freeze it. So this rapidity, it prevents ice crystal formation. So what is the advantages of this vitrification is, it prevents the ice crystal formation and thereby avoid any damage to the embryo. So there is high survival rate following vitrification. So definitely the survival rate of embryo is higher following the vitrification rather than slow freezing. Now, how you can cryopreserve this embryo? So it can be cryopreserved at any stage. So from the pronuclear stage up to the blastocyst. Okay, so you can cryopreserve day 1 embryo up to day 6 embryo. Now, during culture, so basically before vitrification, what you have to see is, you have to see that the embryos are not gone in the arrest, because at some points the embryos fall, that is they stop dividing. Okay, they stop developing because of some either genetic problem, chromosomal problems, or whatever. They may stop developing or stop dividing. So such embryos, to avoid such embryos from vitrification, what you have to do is postpone the cryopreservation until blastocyst stage. So this stoppage of development, it is called as embryonic arrest. So it may be due to chromosomal abnormalities, oxidative stress, or inability to activate specific genes. So to avoid this embryonic arrest problem, what you have to do is postpone the cryopreservation until blastocyst stage, so that you are doubly sure that you can see the embryos which are viable, and you can avoid freezing the embryos unnecessarily. Okay, so in UK also, blastocyst is the preferred stage of embryo freezing. And remember that improved live birth rates are observed following the transfer of blastocyst. Okay, transfer of blastocyst. Cryopreserve, when you transfer cryopreserved blastocyst, and when you transfer cryopreserved early embryos, the live birth rates are improved with the blastocyst transfer. So most of the time, blastocyst is the preferred method of embryo transfer, even for freezing also. So now what are the indications for freezing? Okay, so freeze all strategy. So you are not going to transfer anything, okay, in the fresh cycle. You are just going to stimulate the cycle, and you will not transfer any embryo in the fresh cycle, but you are going to freeze all. So what are the indications for this freeze all? So freeze all is, they can be either acute indications or planned indications. Okay, so acute or unplanned. So actually you have decided to transfer, but you couldn't do it. So what are the conditions which can give rise to such this thing is ovarian hyperstimulation. OHHS, you can't transfer the embryos. In case of severe or moderate OHHS, it is better to freeze all. Uterine abnormality identified during ovarian stimulation, like polyp, okay, or fluid in the endometrium, which decrease the chances of success, decrease the success rate. So in that case, better to do the polypectomy and then transfer. So in that case, freeze all is preferred. Complications of any egg collection procedure, like any hematoma formation, any bleeding, any infection, or any damage to the any other organ. Social factors, that means the patient may unable to attend the embryo transfer or needs to defer the pregnancy because of her any social engagement or any social bindings. Okay, then raise progesterone on the day of trigger. So this is a relatively new thing. So what you are going to do is, you have to do the progesterone on the day of trigger. That means 36 hours before the oocyte collection, you give either SCG or GnRH agonist trigger. So at that time, you have to do the progesterone. So it is shown that this raised progesterone at the day of trigger, it decreases the implantation rate and it decreases the pregnancy rate also. So if you find that there is raised progesterone, better to freeze all. And planned freeze-all is advised in some cases. So planned freeze-all means before undergoing the cycle only, you will decide that you are not going to transfer, but you are going to freeze all the embryos, and it is called a segmented IVF. So that means in one cycle you are going to stimulate the eggs, you are going to retrieve the eggs, and you are going to transfer these embryos in another cycle. It is known as segmented IVF. So what are the indications for this planned IVF? Planned freeze-all is pre-implantation genetic diagnosis when it is required. Okay, Dr. Bijoy, you have missed 2-3 slides. So no problem, I will give you the PowerPoint. Okay, there is nothing much in first 2-3 slides. So planned freeze-all is done in pre-implantation genetic diagnosis. So you have to select the embryos which should be transferred. In case of fertility preservation, like gynecological cancers or other cancers, where you are going to just preserve the oocytes or embryos. In case of recurrent implantation failure, now it is shown that sometimes the ovarian environment or the environment after control stimulation, when you stimulate the ovaries, there might be some toxic environment is produced, and it might be responsible for recurrent implantation failure. So in that case, you can freeze all and you can transfer these embryos later in the next cycles. Okay. So these are the indication for planned, and above I told you these are the acute indication or unplanned. So rate of OHHS is 7% following fresh transfer, while in freeze-all, the rate of OHHS is only 1 to 3%. Remember that. So in fresh transfer, rate of hyperstimulation is 7%, while in frozen transfer, it is. So if you freeze all the embryos and you don't transfer, then OHHS incidence is reduced to 1 to 3%. Now, is there increased live birth rates with a planned freeze-all? Okay, so is it a good strategy to to freeze all the embryos and don't transfer any fresh embryos in the fresh IVF cycle? So actually, this is a controversial thing, but the things which go in favor of freeze-all are, so the reasons which are postulated for the freeze-all technique is because when you stimulate the ovaries, there are supraphysiological hormone levels because you are going to give these gonadotropins. So these are supraphysiological hormone levels which may adversely affect the endometrial receptivity. Okay, it can reduce the pregnancy rate and also impact perinatal outcomes. Also, we always say that this endometrium should match with the embryo, correct? So day of endometrium, so endometrial implantation and embryo maturation should be in synchronous manner. So sometimes what happens is in the ovarian stimulation cycle, this changes in endometrium occurs earlier. So if you do the embryo transfer, sometimes this endometrial changes have gone, they are way ahead of this embryo day. Okay, so sometimes it can be also reason for the failure of in the natural cycles. Also, sometimes this ovarian hyperstimulation or ovarian stimulation, it may negatively affect the expression of specific proteins known as integrins. Those are essential for implantation. So basically, these are the three reasons they are postulated for freeze-all technique in favor of. So one is the supraphysiological hormone levels, which affect the endometrial receptivity. Another thing is endometrial changes, they are way ahead from that of the embryo. And another thing is ovarian stimulation may negatively affect the some proteins which are necessary for implantation. So it has been postulated that it can be corrected by freeze-all technique and you can transfer this in the next fresh cycle. Okay, but as I told you previously also, this is controversial because the meta-analysis, they have found there is no difference in the live birth rate between the patients undergoing elective freeze-all versus fresh transfers. Okay, so this is the thing which is not for all. Another one thing which is the theory is postulated is, as I told you, premature progesterone rise. So sometimes the patients who have this premature progesterone surge, so for those patients, this freeze-all strategy can be beneficial. So what happens in this progesterone surge, premature progesterone surge? So when you give this SCG trigger, okay, or GnRH agonist trigger, it is administered around, as I told you, 36 hours before the oocyte retrieval. Okay, to induce this oocyte maturation. But sometimes because of all these supraphysiological FSH, LH levels, so sometimes it can be, it has seen that a progesterone is prematurely inhibited in the day of the trigger. Actually, according to the normal physiology, progesterone should start after the ovulation, correct? Progesterone rise starts after the ovulation, but in this ovarian stimulation cycle, sometimes it is observed that it is starts with the day of the trigger only, it seems. Okay, so in that case, again, it will cause that asynchrony between endometrium and the embryo. So for that, you can freeze all embryos and then transfer it in the another cycles. So what are the thresholds for the serum progesterone they are suggested? So it is between 2.9 to 6.4. Okay, so this two some people are taking this progesterone level rise with 2.9. So there are different values, it is not defined, so it requires further research where to recommend such things, to freeze all technique in premature progesterone surge. So it is more research is required in that matter. So what are the maternal and perinatal outcomes which is found with this frozen embryo transfer? So frozen embryo transfer, it is associated with low risk of preterm, low birth weight and SCA, but there is increased relative risk of gestational hypertension and postpartum hemorrhage. So with frozen transfer, increased postpartum hemorrhage is increased gestational hypertension and high birth weight, while there is low incidence of preterm, low birth weight and SGA. So now exactly what are the recommendations? So until the outcome of further trials are available, an individualized approach seems to be most appropriate, with the freeze all is reserved for high responders. So freeze all strategy should be reserved for high responders only. And what do you mean by these high responders? So high responders is where the AFC is more than 15, antral follicle count is more than 15, and with these patients, the higher ongoing pregnancy rate has been observed with frozen embryo transfer compared to the fresh embryo transfer. So it is recommended for only high responders. Now, how you are going to do this frozen transfer? So frozen transfer, you have to prepare the endometrium, because you know in the like you have frozen the embryos. Now in the next cycle, how you are going to transfer it? So for that, definitely the endometrium should be receptive. So how you are going to make this endometrium receptive? So there are 4 ways in which you can do the endometrial preparation for this frozen transfer. So one is natural cycle. The second is modified natural cycle, hormone replacement cycles, or medicated. So this is the thing which is basically done previously or right now also, but it is the most commonly done, that is medicated frozen transfer and ovarian stimulation. But till now, optimum protocol which should be followed is unknown. Okay, so it depends upon the clinician's choice what exactly they will use. Okay, so now I will give you the differences between how each cycle, how endometrium preparation done for each method. So see this natural cycle. So in natural cycle, what you're going to do? Nothing. Okay, you're not going to give any estrogen, you are not going to give any trigger like SCG or GnRH agonist, you are not going to give any progesterone also. So remember well, for natural cycle, no progesterone also for luteal phase support. Okay, so natural cycle frozen embryo transfer, there are no drugs, but what you are going to do is you are going to do the endometrial, the ultrasound monitoring for dominant follicle and endometrial thickness. Okay, so when endometrial thickness is more than or equal to 7 mm. Okay, so here when it comes to the ovulation stage, that is dominant follicle and endometrial thickness is optimal, that time you are going to do this monitoring most frequently. Okay, and you can do the either urinary LH or serum LH levels to see for the ovulation or LH surge. Then once this frequent monitoring is over and now you are confirmed of this LH surge and ovulation, then you can decide. So this is the day of ovulation. So after this day of ovulation or LH surge, if you are going to transfer the blastocyst, you have to do it at the 6 to 7 days of LH surge. Okay, so blastocyst transfer is done at the 6 to 7 days after the LH surge, and before that you have to confirm corpus luteum by ultrasound. And When you are doing blastocyst transfer, remember well, when you are doing blastocyst transfer, you are going to do the pregnancy test on 11th day after the embryo transfer. So this is the important thing. So you will be doing this in a pregnancy test after at day 11 of embryo transfer when you are doing blastocyst. And blastocyst you are going to transfer on day or day 7 of this LS search. Now, what do you mean by modified natural cycle? So here you are not going to give any hormone or any ovulation induction for follicle maturation, okay, or not for anything for endometrial preparation also. So in modified natural thing, what you are going to do? You are going to observe for dominant follicle and endometrial thickness, okay. So from day 9 you are going to do this ultrasound monitoring for dominant follicle and endometrial thickness. So once this dominant follicle reaches at the level of 16 to 20, you will give SCG trigger. So what is different from this natural cycle? Here you are going to give SCG trigger, okay. SCG trigger, so that means SCG trigger is same, it is similar to LS search, correct? So after that, you are going to do USG to confirm the corpus luteum, and then you will do the embryo transfer, same, or blastocyst transfer at day 6 to 7 of SCG trigger, and UPT on day 11 of embryo transfer. Here another additional thing is you are going to give progesterone for the luteal phase support. Here you can give any choices of yours, that is vaginal, rectal, IM or subcutaneous progesterone. Okay, so natural cycle, there are no drugs, only ultrasound monitoring, no progesterone also. Modified natural, you will be giving SCG trigger and progesterone, no other drugs for modified natural. So what are these advantages of this natural or modified natural cycles? So no need of medication or very minimal medication you will give for modified natural. It is cheaper than medicated frozen cycles. Okay, medicated frozen cycles, it is very much cheaper than those. Disadvantages, it requires intensive ultrasound and endocrine monitoring, requires ovulation, no control over day of embryo transfer, because there is no control over LS search, because it is we can't predict ovulation, we can't predict LS search. So embryo transfer may come on a weekend also. So there is no control. And cancellation rate. So if ovulation doesn't occur, if endometrium doesn't come to the level of 7 millimeter, then you have to cancel the cycle, and cancellation rate with natural cycle is 8 to 15%. Okay, 8 to 15%. Now, what are these advantages of this medicated frozen thought? So I will tell you what is this medicated frozen thought embryo transfer. So advantages of this is permits embryo transfer in anovulatory. So in anovulatory patient also you can do transfer. How I will going to show you. Allow choice over day of embryo transfer. Okay, so because you are going to decide when you are going to do the trigger, so you can have the choice. In case of thin endometrium, you can increase the dose of the estrogen, because in medicated frozen transfer, what you're going to give, you're going to give estrogen externally. So here you can increase or modify the dose of estrogen and also route of estrogen. Woman may feel more in control, because it can be properly planned. Cycle cancellation rates are very low, that is 1 to 2%. But disadvantages are you have to give prolonged course of medication, it may have adverse effect, and it is more expensive. So what is this medicated frozen embryo replacement cycle? So here what you're going to do, from day 2 you are going to start estrogens, okay, for endometrial priming. Basically it is for endometrial priming. So you are going to give external estrogen, and you have to see for this endometrial thickness for 7 millimeter or more. And once endometrium is 7 millimeter, there is no need to give any trigger. There is no need to give any trigger. Once it becomes 7 millimeter, you can directly start progesterone, and you can do embryo transfer on day 5th or 6th day of starting progesterone. And here you can give progesterone either vaginal, rectal, intramuscular or subcutaneous. And then here, as you have already started estrogen and you have started progesterone, you have to continue estrogen and progesterone up to 10 weeks or sometimes up to 12 weeks also, okay, till the placental function takes over. Okay, so in medicated, yeah.
Ma'am, sorry to disturb, ma'am. The day 2 was decided according to a menstrual cycle, ma'am.
Yes, it is according to menstrual cycle because it is
Okay.
frozen cycle, no? So always day 2 is day 2 of menstrual cycle. Okay.
Yeah, I thought because she's anovulatory, her cycles are also irregular. That's what I thought. Okay, ma'am.
Yeah, whatever it is. If it is anovulatory also, if it is irregular also, you have to give either withdrawal lead, okay, or you can start with her normal menses whenever it comes. Okay.
Okay, okay, ma'am. Okay, ma'am.
Take it as day 2. Okay. Yeah.
Okay, ma'am.
Yes. So here, because sometimes as she asked this question, so sometimes the cycles may be anovulatory periods are very much irregular. So sometimes the estrogen level, okay, estrogen level might be, endogenous estrogen may be high. So to suppress that thing, what you have to do is you have to do pituitary separation. We don't know how much it works, okay, and there are no perfect criteria also what you have to give for this pituitary separation, but there are 3 things that you can do. Either you can give GnRH analogs 3 weeks before commencing to estrogen, okay, to down regulate the pituitary, or you can give GnRH antagonist within first 7 days of cycle, or there can be no estrogen, no supplementation, no supplementary pituitary hormones, okay. So you can do either 3 of this. Either you can give GnRH agonist, you can give GnRH antagonist, or you can't, there is no need to give any medication. You can start directly on the estrogen. So directly estrogen is usually started with normal period people, okay. So here their hormone levels are seems to be normal levels, and there they can you directly start the estrogen. So what is this ovarian stimulation? So this is now the 4th one. Okay. So first we have seen natural and modified natural. First 2. Third thing is medicated, what we have seen before. So it is only estrogen. Estrogen plus progesterone is the medicated cycle. And then ovarian stimulation cycle. So here ovarian stimulation means what you are going to give. Either we can give clomiphene, either we can give letrozole, or we can give gonadotropins to cause ovulation. So it is like mild ovarian stimulation, not like IVF ovarian stimulation, but just mild as we give for induction. Okay. So for one follicle only. So it is mild ovarian stimulation. You can give either clomiphene, letrozole, or low dose gonadotropin. So, but each one has disadvantage because clomiphene, you know, it decreases this estrogen and it can cause this thin endometrium. It has anti-estrogen effect and it causes thin endometrium, clomiphene. Gonadotropins, it is very difficult to monitor this gonadotropin. So, decide the gonadotropin protocols and they are costly. So, this is the disadvantages of gonadotropin. But now the third thing, as the letrozole, they have shown that still it is actually not recommended in UK. But now people are giving letrozole. It is non-licensed drug, but they can give. They are giving in UK for this frozen embryo transfer. So exactly why they are giving letrozole is in the favor because it increases the endometrial expression of integrin. So it increases the endometrial receptivity. So letrozole is shown to increase implantation rate. Also, letrozole requires fewer days of medication. And small retrospective study shown that equivalent clinical pregnancy rate. But to recommend letrozole, more research is required. So, of all these 3, letrozole is preferred one for stimulatory cycles. So when you use this ovarian stimulation cycles, advantages of this is it permits the embryo transfer in anovulatory women also who do not want this medicated or estrogen cycles. May involve fewer days of medications. It relies on endogenous estradiol, so it may be beneficial in those with absorption issues, absorption of estrogen. The disadvantages, it requires intensive ultrasound monitoring. Medication may sometimes cause adverse effects. Gonadotropins are associated with OHHS. Clomiphene may have thin endometrium, and gonadotropins are expensive. So now what is the endometrial thickness is required for frozen transfer? So actually it is a controversial topic, but what the cutoff usually taken is 7 millimeter. So it should be either 7 millimeter or more. Okay. So for frozen transfer, it is for fresh transfer, correct? Fresh transfer, it is 5 millimeter. At least it should be 5 millimeter according to nice fertility guidelines. But for frozen transfer, that telling that it should be at least 7 millimeter. Now, how you are going to calculate the EDD depending upon that? Because we saw in IVF, what we have to do is we have to see the ovulation, oocyte retrieval date for EDD. But here, how you are going to calculate the EDD is here, because the day of egg collection seems to be similar to the ovulation date, correct? So it is around 2 weeks after the LMP. Here, what happens in when you transfer the blastocyst? Okay, so blastocyst, you have to add 2 weeks plus the age of embryo. So it will be 2 weeks plus 5 days when you transfer the blastocyst, okay, from the LMP. So from the LMP, it is considered as 2 weeks plus 5 days. So when you are going to do the pregnancy test is 11 days after blastocyst. So it becomes 4 weeks, 2 days. It becomes 4 weeks, 2 days. Now, this is most important part of this talk. So, what are these legal implications of frozen transfer or whatever? So, in UK, the maximum period the embryo can be stored is only 10 years. Okay. So, routine, the patients who are undergoing IVF cycles for the fertility, the maximum period is 10 years. But it can be extended to 55 years who are for women who are likely to become prematurely infertile like gonatoxic therapy. So the patients who are on cancer treatment, for them it can be preserved up to 55 years. Okay, so once this 10-year period has been gone, then if they want to preserve the embryos, it is not provided on NHS funding and it has to be done through the private laboratories. And the private laboratories, they may cost from, actually the cost is very high. I think it's around 500 pounds. Okay, so it is very costly thing for yearly, I think 500 pounds. So it is very costly thing for them. So now they are fighting in the court for this period of storage. But one thing is there, according to the NHS funding criteria, once the patient becomes pregnant after the embryo, okay, after the embryo transfer, so they can't have another IVF cycle. Okay, they can't have another IVF cycle. So for that, so the patients or persons who have completed the family, it can be a difficult decision to what to do with these embryos. So there are three options available to them. So either they can discard the embryos or donate the embryos for training or research or sharing to the other patients, or they can donate to other patients, donate for research and discard. So these are the three options available. So they have to take the decision. Now here the one thing is there, remember well, the embryos are known to be property of two people. Correct? It is the husband and wife or partner. Okay, two partners. It is responsibility of two people. So consent of two people is required before the transfer or whatever. What has to be done? Okay, whether to discard, whether to donate, whether to share it, or whether to transfer it. For whatever is the thing or that has to be done with the embryos, consent of both people are required. If even they get divorced also afterwards, the both people are consent of both people are required, and if the consent of one person is not there, you can't transfer the embryos. And in case of surrogacy, you should obtain the consent from surrogate also. So it becomes the three persons. And remember well, it is for donor gametes also. Like you have taken the eggs from the female or oocytes from the female, and male is azoospermic, so you have taken semen from donor. Okay, donor sperms if you have taken, the female gamete is from her own partner. So when you are taken even donor semen or donor sperm also, you have to take the consent of the two people. That means the husband and the wife or the two partners is required for transfer, and the consent of donor is not required. Remember well, consent of donor is not required. The consent of the partner is required for this transfer. So here for this consent matter, it is required that high quality counseling should be done. Okay. So when the couples create and freeze the embryos together, high quality counseling should be done. In case of fertility preservation, before this fertility compromising treatment, so here the better option is storing individuals' gametes rather than embryos. because if they become divorced, if they take divorce, if they get separated, so that in that case there will be it can be a big issue. If the consent of other person is not there for transfer, then it can create a big issue. So in case of fertility preservation treatment, it is better to preserve the gametes alone rather than the embryos. So am I clear with this point regarding this consent? Am I clear? This finishes your frozen transfer. These are the two questions on this talk. One first question, 35-year-old woman undergoing ovarian stimulation prior to IVF treatment. She has a history of polycystic ovarian syndrome. She is having interfollicle count to decide whether to have fresh or frozen embryo replacement. So what level of interfollicle count you suggest? Greater success with frozen embryo transfer. So answer is yes. So answer is E. It is 16 to 18. Okay. And the next question or the last question is, a nulliparous woman has cancers and she requires cytotoxic chemotherapy, which may render her risk of premature ovarian failure. She elects to have oocyte retrieval and cryopreservation of embryo at 35 years of age. So what is the maximum period this patient's embryo can be stored? It is up to 55 years for gonadotoxic therapy. It is up to 55 years. So now, right now, she is 35 years. So it is up to 20 years. Okay. Next 20 years. Answer is D. Yes. Till age 55. So it is 20 years. So answer is D. 55 is not there. She is 35 now. So you can store it for more 20 years. Got it? So here the answer is D. So these are the two strategy questions. So we have finished this talk today.